Good evening, everybody. I'll welcome you all to yet another interesting webinar from Yashoda Hospitals. So today we'll be discussing community-acquired pneumonia with ARDS. To guide us through, we have two senior clinicians as well as academicians. Dr. Rahul Pandit, he is a Director Chair, Critical Care Medicine, HN Reliance Hospital, Mumbai. I welcome you, sir, on board. And another clinician, senior and teacher, Dr. Shrikant Sahasrabuddhe. He is a Director Critical Care Medicine, Kamalan Bajaj Hospital, Chhatrapati Sambhajinagar. I welcome you, sir.
Yeah, hi. Thank you, Durgesh.
So the flow will be our DNB resident, Dr. Vinay and Dr. Vaishnavi. They will be presenting a case. And through that case, whenever you feel anything, sir, you can ask them questions. So that's how the discussion will start. So I'll hand it over to Dr. Vinay and Dr. Vaishnavi to go through the case.
Yeah, thank you, Durgesh.
I welcome you, Venkat sir, also.
Yeah, I thank both Rahul Pandit sir and Srikant Sahasrabuddhe sir for being a part of it. Rahul sir, it is always an honor and privilege to have you on board and have an interaction with our students, sir.
Likewise, Venkat bhai. We are honored that you call us up and involve us in your activities. That's an honor as well.
We grown up looking at you. We inspired by many of your talks and activities, sir. Thank you for being with us today.
Thank you, my friend. Thank you.
And Dr. Srikant Sahasrabuddhe sir, thank you for being with us.
Thank you
For this program also and considering to be a part of our moderation. Thank you, both of you.
Thank you, Dr. Venkat. Thank you.
So over to you, Rajesh.
Vinay, you can proceed with the case. You can start screen share.
Good evening, sir.
Good evening, sir.
Good evening. You can start.
Yes, sir.
Yes, sir. 56-year male presented to the emergency department with complaints of cough with mucoid sputum production since 5 days, fever since 4 days on and off, shortness of breath grade 1 to 2 MRC for 3 to 4 days with no history of orthopnea or PND, aggravated to grade 4 since 12 hours prior to admission. There was no history of travel or sick contacts. Prior coming to the hospital, had a outside admission for 2 days. Past history, he had hypertension on medication of telmisartan 40 mg once daily. Personal history, occasionally alcoholic, chronic smoker. Allergic history, no known drug allergies. In ER, general physical examination, moderately built and nourished, no pallor, no icterus, no clubbing, no pedal edema. GCS was around 13/15. Blood pressure was around 130/90 mmHg. Respiratory rate was 35 per minute and saturations were around 85% on NRBM with 15 liters of O2 per minute. ABG in ER suggestive of pH of 7.46, PaO2 of 55 mmHg, PaCO2 of 30.6 mmHg and bicarb of 21. Patient was in respiratory distress and got intubated in ER and shifted to CT scan. Coming to the systemic examination, respiratory
So Vaishnavi, can I stop you there? Just go back one slide, please. The previous, thank you. Can I ask some question? Is that all right?
Yes, sir.
Sir,
So
definitely.
Yeah, thank you. So Dr. Vaishnavi, looking at this slide particularly, what you've done is perfectly fine. But what is the scoring system which is not used that often now, but was sort of, germinated with the Sepsis 3 trial, Sepsis 3 definition a few years before that we started using it. Something to sort of define with the SOFA score, a shortened form of that.
According to the SOFA score, we can have CNS involvement, sir, respiratory system and cardiovascular system and.
So you heard of qSOFA?
Yes, sir.
What's the qSOFA score here?
SBP less than 90/60.
Components.
SBP less than 90/60, sir. GCS of 13/15 and a respiratory rate of more than 30 per minute.
So here you're scoring 1 point for GCS, 1 point for respiration. Blood pressure you mentioned is quite good here, isn't it? 130 by 90. So 2 by 3 is a qSOFA, so this qSOFA score.
Yes, sir.
Here itself you would come to know that we're dealing with a sepsis, though the qSOFA has never been actually used for patients who are coming through the emergency department as such. But it's a very quick way of understanding that we're dealing with sepsis. Of course, there are other parameters and history which are looked at, and that obviously adds on to the whole story. But here itself, by looking at it, you can say that qSOFA score is quite suggestive of a sepsis going on in the background. Thank you. Go ahead.
Coming to the respiratory system, bilateral air entry was present with coarse crypts that have been heard at mammillary, axillary, and infraaxillary, interscapular, and infrascapular areas. Cardiovascular system S1, S2 were present. No murmurs were heard. CNS confused, erosible, sir, with no focal deficits. Per abdomen was soft and bowel sounds were present. Patient was shifted to medical ICU after 2-day echo was done, and which was suggestive of no regional wall motion abnormality, normal sized chambers, no pericardial effusion, with ejection fraction of 55% with fair LV functioning, with grade 1 LV diastolic dysfunction. IVC was around 1.4 centimeters. Sir. He was sent for CBP, RFT, LFT, serum electrolytes, and also CRP at the ER only, sir. They have sent. This was the chest X-ray which was done, and this was the CT. 1 second, sir. Which was done in the ER.
That's your day 1 CT scan?
Yes, sir.
On admission CT scan?
Yes,
Okay.
sir. On admission CT scan. We diagnosed it as a severe community acquired pneumonia with type 1 respiratory failure with moderate to severe ARDS, sir.
Your PF ratio was what? Now at this stage after intubation? This was on intubation, the ABG was on intubation or off intubation?
Yes, sir. ABG, 1 second, sir. The PF ratios were on FiO2 of 100 and...
No. The previous ABG which you showed us on the second slide, this ABG.
NRBM, sir.
NRBM.
It was an NRBM. Okay. So what is the newer definition, the global definition of ARDS? How would you sort of go on this ABG and tell me whether this could be included or not? You have an X-ray now, you have a CT now, and you have an ABG now. Can you tell me the newer definition of ARDS, the global definition?
According to time of onset, it should be within 7 days, sir, without any risk factors prior. Now, new global definition of 24, it has been suggestive of instead of X-ray and CT scan, we can also use ultrasound findings for telling whether it is a consolidations have been present or not. And pulmonary edema, which has been not explained by any cardiogenic part or any fluids that has been given prior. And also based upon the oxygenation, PF ratios has been given as if it is mild, 300 to 201, sir. If it is moderate, 201 to 100. If it is severe, less than 100, sir. And newer definition also included the requirement on non-intubated patients. If at all present on NIV or HFNC, NIV or CPAP with more than 5 of PEEP, sir.
NIV HFNC of more than 30 liters per O2, sir, per minute, and HFNC of with 5 centimeters of 5 centimeter water of PEEP. With SF ratios of around for mild it's 315 to 235, sir, and moderate it's around 235 to 148, sir, and severe it's less than 148. Sir.
So two big differences between the Berlin definition. You have already covered all of that. But the answer expected here would have been crisp. But apart from the standard 2012 Berlin definition, The two changes which have happened is that you don't have a requirement of a PEEP of 5 now. So you can include patients with HFNC, and you have an SF ratio now as opposed to a PF ratio, which actually allows you to have include patients. Resource limited setting, the PF ratio may not be quickly available for you.
Yes.
So these are the two things. That's how I would like an exam answer to be given.
Okay, sir.
Apart from the Berlin definition, these are the two global definition additions.
Yeah. Excuse me, can I ask a question?
Yes.
Yes, sir.
Yeah, so two questions actually. So this new definition has already been covered. So how can you quantify the pneumonia? You have this kind of X-ray shadows. So have you heard of any scores or any curb 65,
Yes.
which is not very commonly used, but I think you should know that. And
Yes.
secondly is before you did a CT scan for this patient, did you look at the ultrasound yourself for this patient? Did
Actually,
you attend this patient?
yes, sir. After coming to the medical ICU, we have seen the POCUS, sir,
Yeah.
which was suggestive of B lines, sir, and around the lower part of the lung, there was a lung shredding sign was present, sir.
What is the pathognomic feature of consolidation on ultrasound, and what is the sensitivity and specificity of ultrasound?
Pathognomic feature is shredding sign with air bronchogram, sir.
Sensitivity is around 92%, sir. Specificity of around 98%.
Yeah. So what are the types of air bronchograms on ultrasound? You
Static
know?
and dynamic air bronchogram, sir.
Yeah. So in consolidation, you expect
Dynamic air bronchogram, sir.
Yeah.
Collapse, we expect static.
Air bronchograms.
Right. Anything else you see in consolidation?
C lines is most common, sir, compared to B lines, sir.
Right.
Yes, sir. Thickening of pleural line and irregular pleural line and thickening of the lines, sir.
Irregular pleural line, yes. And anything about curb 65? Like
Most commonly used it for admission in ICU or OPD,
Right.
sir.
Right.
It basically designed for to stratification of mortality.
Right.
And for curve 65 is for confusion, uremia, blood urea levels of around more than 20, respiratory rate of more than 30, and BP of systolic BP less than 90, and age of more than 65, sir.
Right. So in your patient, I think the score, what was the urea? It was not there, but anyways, it seems to be more like if it is more than 3, then it is not a good sign. So I think it fits. Yeah, the patient was confused, right?
Yes, sir.
The patient was confused. Patient was tachypnic. So you're already 2 points.
2 points.
The patient is less than 65, and urea maybe, I don't know, you can see the reports. But yes, you should just know about if you're presenting a case of community acquired pneumonia. So when you look at the patient, what do you feel? What could be the reason for this patient to have a pneumonia? Why should this patient have a pneumonia?
Because of
might be no smoker, chronic alcoholic, and hypertensive. There is a high chances of community acquired pneumonia, sir.
Okay, so he's a smoker, so there's probably a underlying COPD.
Sir.
Was there any history suggestive of COPD? He was on any long-term inhaler therapy?
No, sir.
Okay, because the pack years were significant. Yeah, okay. Okay, you can go ahead.
The treatment which was started was injection piperacillin tazobactam 4.5 gram IV QID, injection doxycycline 100 mg IV BD, capsule oseltamivir 75 mg BD, anticoagulation with dalteparin 5000 units subcutaneous OD, injection furosemide 20 mg IV BD, injection optineuron 1 ampule IV OD. The patient was shifted to medical ICU with volume control mode of FiO2 of 100, PEEP of 12, tidal volumes of around 420, respiratory rate of 20 per minute based on the predicted body weight of 72. And after coming, we have checked the P plats, which were around 27, and driving pressure of 15, and saturations of around 88. We have repeated the ABG on arrival to the medical ICU and counseled the family members. And we have sent 2 sets of blood cultures and started on infusions of fentanyl 10 mics per hour and etrachirum 25 mg per hour in view of ventilator asynchrony.
Okay.
After 2 hours, the ABG was repeated, which was suggestive of FiO2 of 100, PEEP of 12, saturations were around 85. The ABG was pH of 7.36, PaCO2 of 42, PO2 of around 120, and bicarbonate of 23, and PF ratios were around 120, sir.
Okay.
Attenders were counseled and decided on proning the patient, secured the lines, and proning done for 16 hours, sir. We have started on feeds of 50 ml per hour, and after 4 hours of proning, the pH was, we have done in ABG, the pH was around 7.36, PCO2 of around 44, PaO2 of around 180, and bicarbonates of 24, sir. And PF ratios have been improved from 120 to 180. We have continued the proning. And we were able to come down on FiO2 of 50, PEEP of around 8, tidal volumes 420, respiratory rate of 20, saturations of 92 on mechanical on monitor, sir.
Dr. Vinay and Dr. Vaishnavi, can you justify the antibiotics used? Nothing wrong in them, but I want to hear a justification from you. How would you justify your antibiotic and antiviral use, which you have used?
He was having outside admission for 2 days, sir, and also he was a chronic smoker. We expected that he might have a Pseudomonas induced community acquired pneumonia. So we thought of keeping a beta-lactam BLI cover, sir. And for covering oseltamivir, according to ATS IDSA guidelines, we can we have to cover with viral infection for 2 to 3 days until the panel comes negative, sir.
What is the sensitivity of community-acquired Pseudomonas? Because you seem to have used an anti-Pseudomonal agent, which is perfect. What is your resistant pattern of Pseudomonas that you find in the community? Is it a sensitive Pseudomonas? Because hospital-acquired almost most of the Pseudomonas strains are resistant strains, isn't it?
Resistance, sir.
Is Pseudomonas a very common bug in smokers?
Yes. Usually streptococcus pneumonia is the common.
And COPD, there is a risk of Pseudomonas is there, sir. That's why we.
As he was a chronic smoker for around 30 years, we thought of X-ray was suggestive of COPD, sir. So we thought of
X-ray was, you could see hardly anything on X-ray.
Yes, sir.
X-ray was pretty bad. CT was horrendous. We agree on that. And why doxycycline? Why not? So again, don't get me wrong. I am not questioning your choice. I want a justification. That's what I want as a student. You have chosen something. I'm very happy. But what's the justification of that?
Doxycycline for atypical coverage we have added, sir.
So if I may be a devil's advocate and ask you, why not a macrolide or a quinolone? 56-year-old, no contraindication for either of them.
Yes, sir.
Might be initially we thought of any topical sepsis also might be there, sir. That's why we used a broad spectrum doxycycline, sir.
Okay, I am very happy that you could bring that out and justify the use. That's fine. Now tell me, if you are giving this, you've collected any cultures?
Yes, sir.
What cultures have you collected?
Blood cultures.
Blood cultures we have sent, sir.
Okay. And the patient was intubated. Did you think of sending any tracheal cultures?
Actually, we thought of sending tracheal culture, sir. We have discussed with the pulmonology team. There was a plan of bronchoscopy, sir. So we waited on sending tracheal cultures, sir.
Okay, let me be again a devil's advocate. Which are the 1 or 2 conditions where you don't have to wait to give antibiotics before the cultures are collected? One of them is, of course, community-acquired pneumonia. The other one is obviously meningitis. But in this patient, because you are intubated the patient in the emergency department itself, you could have done a non-directed bronchoalveolar lavage or a mini ball, what they call it. What's the specificity and sensitivity of a mini ball? And how do you do it? Can you describe it?
Mini ball, we will send a suction catheter, sir. soft suction catheter into the ET tube, and then we will do a gentle suctioning, and off that first sample will be discarded, sir. Further sample will be collected, sir.
Not really. You
Okay.
can you say anything better than that you could say? So what we usually do, so many non-directed bronchial or lavage basically means that you take a sterile suction catheter and you attach that suction catheter to a mucus trap, and you have a 20 ml of saline present with you, okay, in the syringe. So you insert the suction catheter wearing sterile gloves and everything with cap, mask, gown, as you would scrub up for your central line.
Okay, sir.
Let it go to the end of the beyond the endotracheal tube till it goes and hits either the right main bronchus or the left main bronchus and goes inside one of the bronchus. As we all know, most of the time the catheters go into the right main bronchus, not the left main bronchus, correct?
Yes,
So
sir.
once it sort of goes and hits and does not go any further, you stop at that point, squirt in 20 ml of saline, and wait for around 10 seconds. And then you attach your mucus trap and just suction it from that point. Do not come suctioning out. You've got to just suction it from that very point.
Okay.
And whatever aspirate you get, 5 ml, 4 ml, 6 ml is what you would probably aspirate out of the 20 ml. That's the sample which you send. That has got a specificity and sensitivity of almost 97-98% to a bronchoscopic guided bronchoalveolar lavage. So don't forget, it's very easy.
Okay,
It's
sir.
an easy procedure to do. And especially if you have an intubated patient. If you don't have an intubated patient, of course, it's out of question.
Okay.
But if you have an intubated patient, a non-directed bronchoalveolar lavage has got a very good specificity and sensitivity. Go ahead, guys.
So if I may ask, like, just a couple of questions. So I completely agree with Dr. Rahul that you should not have waited for bronchoscopy because,
Okay, sir.
see, when the patient is on 100% FiO2, I am sure I myself is a pulmonologist. I would probably not go ahead and do a bronchoscopy straight away. I would actually advise a mini ball at
Okay.
present point in time because we want a diagnostic, because we don't want any therapeutic at present. We want a diagnostic, and the cutoff is 10 to the power 4, which is equivalent to the bronchoscopic bulb. So I will not have any added advantage of waiting for a bronchoscopy for the diagnostic yield, where we have a both cutoff of 10 to the power 4 colony forming units. That is one. Second question which I want to ask is, if at all you need to give antibiotics for a community acquired pneumonia patient, what does the present ATS or the ERS guideline suggest, or even for that matter, Indian guidelines, if you must have actually read about?
Yes, sir. According to the ATS guidelines, if it is a OP patient, sir, without any co-morbs, we can add a macrolide, sir, or a doxycycline, sir. If it is a patient is having any comorbidities, then we can go for a respiratory fluoroquinolone, or otherwise with a beta-lactam plus macrolide, or otherwise
Okay.
doxycycline, sir.
Right. So, talking about the Indian context, would you really go ahead and give a quinolone?
No, sir.
Yeah.
Because there is a high chances of TB in the community, and that's
So
why
you need to reserve because it is a reserve drug.
Yes, sir.
Quinolone is a very good effective anti-tuberculous second line drug. So we need to actually reserve it. So obviously in the Indian setting, and they will not translate into the Indian population. If you see the Indian guideline, they will strictly say no to the
Yes, sir.
quinolone group. So obviously we would not prefer a quinolone. And at the same time, I would go ahead with a macrolide rather than doxycycline,
Okay,
because
sir.
if you look at the comparative data, comparing the doxycycline versus macrolide, macrolide achieves a relatively higher concentration in the extrapulmonary lung fluid with a good penetration into the lung. So doxycycline will be a little weak antibiotic as far as such a severe community acquired pneumonia is concerned. So probably my choice would be a macrolide, again based on the Indian guideline, and piperacillin tazobactam is okay. So what is the combination of macrolide otherwise?
Clarithromycin we can add, sir.
500 mg twice
Yeah.
daily we can add.
Yeah. Another thing which I want to ask is, what about, I mean, why did you give a diuretic to this patient?
Actually, he had a B lines on a POCUS, sir.
So
We
B-line
thought,
is even in
yes, sir.
pneumonia, you could have some B-lines anyways.
CT also suggestive of both consolidations with interlobar septal thickening and middle part of the lung.
Little console, right?
Okay.
Pulmonary edema
Picture was there, sir. So we thought of adding.
So on the basis of the
CT.
CT scan and this thing, did you look at the IVC? Do you really feel IVC will be useful? And if at all, what will you see for IVC? And how will it help?
IVC in a ventilated and non-ventilated patients, we have to see for collapsibility.
Yeah, so this is a ventilated, so you will see distensibility, right?
Distensibility index.
So how will you see, and what is the interpretation?
We will see at the subxiphoid view, sir.
Right.
Towards a right tilt, somewhat right tilt towards
Right
Yeah, that's
shoulder.
okay. You may not explain the procedure, but just tell me the interpretation. And
we have to correlate with the respiratory variations have been present or not, sir. Like
what is the cutoff of, like, say, for example, the patient is spontaneously breathing. We talk about IVC collapsibility, where the criteria
less
is
than
cutoff is more than 50% or less than 50%.
50%.
So similarly, in a ventilated patient, you look for the distensibility. So what is the cutoff in that?
Around 1.5 centimeters.
No. I'm asking about the percentage.
Percentage.
It's about 18%. And how
Okay,
will
sir.
you calculate?
Maximum minus minimum by
Means maximum minus minimum by 2.
Okay, fine. Take care. Yeah, please go ahead.
So one more thing, sometimes even a mini ball may be difficult. If you have 100% FiO2 patient,
Yeah,
you got to sort of, just for the attendees who are attending, nobody here, neither me nor Shrikant, are promoting that you have to do a mini ball. Okay, you have to take the bedside doctor is the best judge to actually decide
right.
whether mini ball will be safe or not. While it would be helpful for diagnosis, it may not be the safest thing to do at that time, and you may have to wait for some time.
Right. Right.
These were the day one investigations, sir. HB of around 11 gram per deciliter, TLC of around 14,600, platelet count of 2.9 lakh per millimeter cube, blood urea of around 20, serum creatinine of 0.8. LFT was within normal range, sir. Sodium electrolytes were 136, sodium 136, potassium 3.7, chlorides of around 102. NT-proBNP was 2,240, and CRP was around 294.2, sir.
Okay.
Coming to day 2, the patient was supined at 11 a.m. Chest X-ray was repeated. ABG was done. Suggestive of pH of 7.42, PaO2 of 98, PCO2 of 40, and bicarb of 25. Sir. PF ratios were around 196 and saturations were around 93. At this point, we have performed bronchoscopy bedside. Suggestive of thick mucoid secretions, which were removed and sent for gram stain, culture stain, and pneumonia panels. After that supination, we have done a ABG at after 4 hours on the ventilator settings of FiO2 70, PEEP of 10. Sir. The tidal with a tidal volume of 420, respiratory rate of 22, saturations were around 87. The ABG was suggestive of pH of 7.35, PaO2 of around 85, PCO2 of 44, bicarb of 24, and PF ratios dropped to 121, sir. And at that point, the P plats were around 24 and driving pressure of 14, sir. So decided on the second session of proning, and patient was proned at 5 p.m. Gram stain flagged positive for GPC in PACE. ABG was repeated 4 hours after proning with pH 7.38, PaO2 of 120, PCO2 of 42, bicarb of 24, PF ratios of around 171. Continued proning for 16 hours, supined at 9 a.m. next day. We have come down on FiO2 of 40, PEEP of 8, tidal volumes of around 420, and respiratory rate of around 22, sir. Continued the feeds. Okay,
so 2 questions. You you did all the right things. You mentioned about P-plat and driving pressure. A little bit of commentary on that, each of that, please, from both of you. So, how does it matter for the P-plat and how does it matter for the driving pressure? And one more question, which even I don't have a very good answer for it. Should you be doing all these pressures in prone and supine? Is there a difference between the prone and supine? Or it doesn't really matter? Because prone, you are going to recruit, supine, you're going to basically find out what the patient is. But something about driving pressure and plateau pressure, please.
In a prone position, when we prone, sir, the heterogeneity of the lung may be equally distributed, sir. In such conditions, the measuring of P-plat and driving pressures could be better than in supine position, sir. And for this measurement, the patient should be in a deep sedation such that he should not be awaked because of we give an inspiratory pause, for which the alveoli can be damaged, sir, if at all he is having any ventilation asynchrony. Usually, the driving pressures
Target is around less than
15, sir. It was given by Amato et al. Study, sir. That article was produced in NEJM around 2015, which was suggestive of if we drive the patient with a P-plat, driving pressure of less than 15, it might be
decrease in mortality. Mortality
sir.
benefit is there for recording.
Okay.
And
regarding P-plats, we will target around less than 30 centimeters of water, sir. Usually, the P-plat is the one, when we do an inspiratory pause, sir, the alveoli will be open at that time, and there is a constant pressure which has been maintained within the ventilatory circuit, such that it will give a pressure of around
Hello.
Hello, sir. Yes. We
Yeah, I
got
can hear you. Go ahead.
sir. Target of platelet was less than 30, sir. And we have to check for regularly for every fourth hourly for complaint and to compliance, sir. Best compliance we have to adjust to decrease the plateaus under 30.
So how do you check the compliance? Static and dynamic.
Yes,
What do you check?
If
static
compliance is nothing but change in volume by change in pressure, sir. Static is P-plat minus P, we will measure, sir. Whereas dynamic compliance is nothing but P peak minus P-plat, sir.
Airway resistance also we have to consider in
dynamic,
sir. In static, we have to take note the airway resistance, sir. Patient is sedated at the time.
Yes. Yes. Good. Okay. Shrikant, anything or should we move forward?
Just I had a couple of question on. Am I audible?
Yes, sir. Yes, sir.
Yeah. So one thing is that would you consider steroid at this the point where you had a high FiO2?
Yes, sir.
Or any guideline which support steroid? Are you aware of that?
According to ATS IDSA guidelines, recently they have recommended steroids in severe caps.
Which is the agent? What dose? And what is
stress dose of around 50 mg QID, sir. We can give a bolus dose of 200 mg stat, sir.
No, that is when you have a shock which is set in.
Yes, sir.
But for pneumonia,
Cape Cod trial, sir.
yeah.
In Cape Cod trial, they have used a hydrocortisone of 200 mg, sir.
Okay.
Actually, they have used it for initially 4 days.
Around initial for 7 days and 14 days, sir. For
Right.
7 days they use a low dose, and for 14 days they use a high dose, sir.
And even you find a note of the mention of dexamethasone
Yes, sir.
in the patients.
ARDS,
ARDS trial, sir.
Yeah.
where they have used dexamethasone of 20 mg for first 5 days, sir.
Right.
10 mg later tapered to 10 mg of next 5 days, sir. They have shown that mortality was benefited, but it is not to be superior, sir. But there is a decrease in the ventilator free days and length of ICU stay was decreased according to the DEXA ARDS trial, sir.
Right. So depending on that, how is your approach towards this patients as far as steroid is concerned? Do you use it routinely or you keep it reserved?
We will use routinely, sir.
So you have labeled this as severe cap, right?
Yes,
Yes, sir.
So did you consider that here or?
Yes, sir.
You did not give it, right?
We have given, sir.
Yes,
You
sir.
gave.
Sir, we started on day one only, sir.
Acha, have you mentioned that?
No,
I'm
sir.
sorry. I did not
Please
get
sorry.
It's missed.
Okay. You gave it in this
Yes,
case.
Yes, sir.
Yes, sir.
It's not
Okay.
Cape Cod, it's Cape God.
Yeah.
Steroids are like God. You need to give it to everyone.
Okay. Fine. So that is one. And second is after you looked at that report of GPC, so what do you conclude about for that? I mean, GPC in pairs,
Most common community acquired streptococcus pneumonia.
streptococcus. Yeah. So are you happy with the coverage?
Yes.
Yes.
Yes, sir.
Yeah. You can be, you say it. Yes, you are right. It's not necessarily that if the X-ray is such a bad, you need, highest of antibiotics. It is not like that.
Yes,
You
sir.
need to have appropriate and a rational antibiotics. So you are right here. Okay, fine. Okay, you can go ahead. Please go ahead.
Yes, sir. One second. Panel came positive for streptococcus pneumonia, sir. ABG was around, we have done the ABG. So pH was 7.42, PaO2 of around 90, PCO2 of around 38, bicarb of 24, PF ratios of around 225, sir. After 2 cycles of proning, PF ratios improved. Chest X-ray was this on day 3. Feeds were continued. We have stopped the paralysis agent. On day 4, the patient was off sedation and awake. Weaning trial was started with the pressure support of 8/8 and rapid shallow breathing index was around 74. Hemodynamically stable, resolving hypoxia. After a SBT, we could extubate the patient and supported with face mask of 5 liters O2 per minute, sir. These were the vitals after extubation, and the patient was shifted to step down ICU, sir.
Okay, so two things. One is just go one slide back, please. Yeah, so antibiotics with the pneumonia panel basically confirming streptococcus. Again, as a devil's advocate, could we have gone down to just ceftriaxone or benzyl penicillin?
As the patient was improving,
No, that even I would probably do that. I'm not denying that. But if you are a purist, you would want to go down, right? You
Yes,
don't
sir.
want to
We
now
should
give a
go down, sir.
penicillin tazobactam. You would probably, we do it in Australia all the time. If the moment it comes as pneumococcus or streptococcus in the lungs or in the blood, we just go down to benzyl penicillin or ceftriaxone. You don't really
Yes,
have
sir.
to go up because the moment you start giving them BLI, you're actually having an increased resistance,
Yes,
which
sir.
you're going to see in the community. Unfortunately, everybody is giving it, and most of us sort of like to keep the winning combination going on. But as a purist, we could have easily gone down to benzyl penicillin for this patient. There was no contraindication to give benzyl penicillin, and it would have acted perfectly fine as well. The second is you mentioned about paralyzing agent. So, what are your thought processes of giving paralysis to these patients? How do you monitor your paralysis to these patients? And any trials that you know of which talk about paralysis, either they are for it or against it?
For paralysis, we have accuracy trial and PET trial. In accuracy trial, they have used cisatracurium for continuous infusion for around 48 hours. They have used, sir, which was showed mortality benefit among those individuals, because apart from sedation, it has an anti-inflammatory effect, sir. So most of the studies were done with cisatracurium only, and in a petal study, rose people which they have conducted, they have used, but they couldn't. The study was stopped, and they couldn't find any significant benefit, sir.
Significant mortality benefit, sir. And ventilator free days is also.
So we are left with 48 hours and stop, isn't it? That's what it looks
yes,
like.
sir.
Because
Yes,
there
sir.
seems to be no consensus right now beyond 48 hours.
Yes, sir.
And certainly mortality benefit is not there, but the ventilation seems to be easy, and it makes perfect sense that if you're going to prone somebody, then you need that patient to be
Yes.
synchronizing well with the ventilator at the same time sedated adequately, right?
Yes, sir.
So how do you monitor this paralysis? Is there a paralysis monitoring that you do, or you just give them a standard dose of 0.1 milligram per kilogram? How do you monitor the paralysis?
Hmm.
So in
Actually,
short, I may ask
train
you
of
even
4.
directly. Do you use a train of 4?
Usually, if at all we have that monitor available, we have used only once, sir.
I need to talk to Venkat Bhai at the end of the webinar and make sure that it is available in your ICU. It's a very cheap monitor.
Yes, sir.
Most anesthesia departments have plenty
Yes,
of
sir.
them. You can actually borrow one from anesthesia department, because at any given time you may only have 2 or 3 patients who may be on such kind of paralysis. Most of the times you don't have that many patients on paralysis anyways. And what we generally do, and I recommend everybody, and the standard practice would be that keep a one twitch. So you basically paralyze them till you have one twitch visible, 3 twitches absent essentially. And that's your adequate paralysis. You don't need to sort of go and knock them off completely. So you don't need to fill them up to eyeballs with the paralyzing agent. You just keep one twitch on, and that essentially serves your purpose quite well. And that is shown to sort of decrease the incidence of critical illness weakness. Of course, critical illness weakness is a multifactorial thing. Your muscle relaxants and sedation just is one of the factor which actually affects it. There are so many other factors, but if you can minimize that, it makes a bit of a difference.
Okay.
Srikant, anything from you?
No, I think.
Did we finish the case, or we've got something more going on?
Finished the case. Yes.
So
Finish the
you,
case. Okay.
yeah. So it was weaned and then you extubated and it was shifted. After how many days?
Day 4, sir.
Day 4. Not bad.
So what's the duration of antibiotic would you give for this patient? What did you say to the pulmonologist or the treating team, or maybe whoever was looking after the patient in the ward? You've given 4 days of piperacillin tazobactam.
7
What's
days.
the evidence for duration of antimicrobial agents right now for community acquired pneumonia?
If according to ATF guidelines, if it is a OP based, we can give 5 days, sir. If it is IP based, if it is not a severe cap, we can give for 5 days, sir. If it is a severe cap, we have to continue at least for more than 5 days, at least 7 days.
7 days, yeah.
Sir, we can bring different permutation combination of scenarios to actually put questions across to have more discussion.
Yes. Thank you, Venkat Bhai. Thank you. Now I would like to just add on to what you already have presented. What about Shrikant asked you about furosemide? So how many days did you continue with furosemide? Because anti-pro, somebody's put up on the chat box that anti-pro-BNP was high. So fine, you could justify your furosemide into so many ways. Just that you want the patient to be dry, you would say that anti-pro-BNP was high. I would like the patient to sort of dehydrate a little bit more, better for lungs. Lung is dry, is better for lungs. So how many days did you give it?
2 to 3 days, sir. We will repeat again anti-proBNP on day 3 or day 4. If it is in a decreasing trend, we can probably stop the.
Do you think this patient had cardiac failure? Why was the anti-pro-BNP high?
Heart failure, preserved ejection.
Grade 1 diastolic
Dysfunction was there, sir.
I mean, every 55-year-old hypertensive, you do it, they all will have. I'm sure most of us who would be in 60 and above, if we are taking some blood pressure medicine, and I go to a cardiologist, he will diagnose me as grade 1 and diastolic dysfunction. All of us will go through that. What happens to the right ventricle when you have severe ARDS?
RV
dysfunction will be there, sir.
Your patient did not have RV dysfunction, right? There is always a strain. So anti-proBNP is a very non-specific marker in this condition. Okay, it's not going to help you. Certainly, you should not base your treatment based on anti-proBNP. There might be so many reasons the anti-proBNP will be high. And certainly guiding therapy based on that, it's going to be a very big problem, right?
Okay.
Now, as Dr. Venkat suggested, let's say we are day 3 today, and the PF ratio still remains 100. What are the various options? I would like you to talk to me about lung recruitment, if you do a lung recruitment strategy. And I would like to think you to think about any mechanical circulatory, or not mechanical circulatory, mechanical respiratory devices beyond ventilator.
Actually, recruitment maneuvers, according to the European Society guidelines and ATS, they are against the recruitment maneuvers, sir. If at all we want to do, we can have a continuous CPAP of around 40 centimeters of water for around 40 seconds, sir. Or otherwise, we can have a staircase maneuver where we can ventilate the patient with pressure control ventilation with pressure inspired above the PP is around 15, sir. We have to keep that 15 inspired pressure such that it is a driving pressure in such case, and we have to increase the peeps from 15 to 20, 25, 30 up to 40, sir. 40. Every 2 minutes we will increase, sir. Then afterwards we will decrease back the peep to 25. From 25 we will decrease the peep with the 2.5 difference.
2 centimeter, 2 to 3 difference.
Difference with every 3 minutes, sir. We have to see here for the saturation, sir. If at all the saturations if we make a target of around 90 or 92%, if the saturation has been decreased at a point of peep, at that point, if it is being decreased at 17.5 or 15, at that point of the peep, we have to again increase the peep to 40 for 2 seconds, and then at that 15 we have to add 2.5 and keep that as a suitable peep, sir. But these maneuvers, as they are leading to hemodynamic instability, nowadays these recruitment maneuvers have been not recommended, sir. Apart from that, if at all the patient is, we can have trials of Caesar and Eolia, sir, where we can have.
Just 1 second. We'll come to the ECMO part.
Yes,
so you did a recruitment maneuver?
yes, sir.
What recruitment maneuver did you do?
On initial first day of before proning, we did, sir.
Proning is the best recruitment maneuver right
Yes,
now.
sir.
You know, we all are now recruiting lungs by proning the patients. Where I'm sure in your unit, in our unit, in anybody's unit, nobody is actually
Using
doing the recruitment maneuver physically. We are all sort of proning and recruiting the lungs. Okay. So coming to your ECMO, what are your ECMO criteria that you follow? That you should be referring a patient to an ECMO. Forget about the trial. I would like you to tell me about trial, of course. But what is it that you do at the ground in your ICU? When do you say, Venkat sir, we want to do an ECMO now?
If the PF pressures are not improving, sir, below 100, and the pH
protective ventilation and
proning, sir. If the pH is less than 7.25 and we are not able to achieve the permissive hypercapnia of 60, and it beyond increasing beyond 70, 80, and the pH is not maintaining, in such patients we usually keep them on a ECMO, sir.
So how many days of proning would you try, or there is no such formula that if even few hours of proning, if you don't improve, you would think of?
Yes, sir. Usually for 1-2 patients, we have kept like that, sir, because the pH was we are not able to maintain the pH, and we are not able to achieve the PCO2 levels also, sir. So immediately we counsel the patients, and for one case, female lady, we have placed on VV ECMO, sir.
If any sudden worsening of hemodynamical compromise also, then we can go for ECMO also.
So sudden hemodynamic compromise, would you go on a VV ECMO or a VA ECMO? What is the thought process behind that?
VA ECMO, sir. Any new onset LV dysfunction or stress cardiomyopathy,
The stress cardiomyopathy causing hemodynamic instability, you may think of VA ECMO. Okay. If this patient was referred to you after 10 days, and say another 4 days later, you found that despite 4 days of proning, he still is having poor compliance, the PF ratio is still below 150 or maybe below 100, would you still offer them ECMO?
Yes, sir.
Yes, sir.
But
So other way of
it is
asking this
beyond.
question is there a reversibility? What is the pneumonia process? When do you? So see, yes is a very easy answer. We
Like
all might
we
say yes.
have
I
to.
want you to justify. As students, I want you to justify your answers. Why yes and why no?
Actually, we if at all they have come to us at 10th day or 11th day, we will recheck, sir. We will take a CT, sir. How is the pneumonia condition? We will first check, and we will ask whatever the antibiotics that was properly covered or not. We will see first. If at all antibiotic coverage is good, and we will see for resistant patterns for any MRSA or for any ESBL or any carbamazepine resistance, we have to see, sir. If at all it is not a pneumonia which has been having underlying lung abscess or empyema, if at all we could able to resolve those conditions, we can have a drain which can be keep, sir. Or otherwise we can think about other infections like organizing pneumonia or any hypersensitivity pneumonitis or for any other fungal possibilities, sir. If at all it is not resolving, and then
Non-resolving pneumonia is a problem of multiple issues, as you rightly pointed out. It could be a hypersensitivity, it could be a bronchiolitis obliterans, organizing pneumonia. It could be a combination of heart failure because of stress cardiomyopathy along with community acquired pneumonia. It could be a lung abscess or bilateral pleural effusions because of profound heart failure, which may be mimicking like a pneumonia and ARDS. So you have multiple things. My question is still a bit different. Let's say this is pneumonia, this is ARDS,
okay, sir.
and the patient is with you for after 2 weeks, has come to you now.
Yes, sir.
When is the point when you say, so yes, saying yes for ECMO is easy.
Yes, sir.
When is saying no for ECMO? What are your criteria for saying no for ECMO?
Yes,
We have to again check for CT, sir. Any fibrosis is there,
CT scan,
then
would you treat or would you treat the patient?
sir.
sir,
Or both?
We
sorry, sir. Pardon.
Would you treat a CT scan and then treat? Would you see the CT scan and then treat the patient?
no,
That
sir.
means
We
No,
will
sir.
treat the
We will
patient.
treat, sir. For ECMO,
We will give an
Well-
option of ECMO to the attender, sir.
Both of you take the attendant out of the picture. I'm not trying to pull your leg. I'm honestly asking a question. When would you say no for ECMO? Let me ask it point blank. What are the contraindications for ECMO? When would you say no? Suppose this was 21 days. Let me put it a very clear cut case. 21 days, patient referred to you after 2.5 weeks, 3 weeks. Would you still go for ECMO?
No.
No, sir. Fibrotic lung already X-ray2 and followed by fibrotic stage is there. There is no point in going for ECMO.
So one is that if the pneumonia has reached to a point of irreversibility where there is damage to the lungs, then you have to see the reason I'm asking this is all of us do ECMO nowadays quite often. It's very easy to say yes for ECMO, but one question which all of you should answer before going on ECMO is ECMO to what? Is this ECMO to recovery? Or is this ECMO as a bridge towards transplant? These are the two things which you need to ask. Now, quite often you are a quaternary care hospital, tertiary care hospital where lung transplants are happening. So is our hospital. But not every hospital has that luxury
Yes, sir.
of having a lung transplant as an option at the end of it. Okay. So in a general situation, your answer should be what? ECMO to what?
Yes,
And
sir.
if ECMO to what answer is still that ECMO to recovery, and you may have your reasons for recovery. Reasons for recovery could be CT scan not suggestive of a fibrosis, or CT scan suggestive that we still have an active demonic process going on and there is some reversibility possible. Or you may have a patient who has a hemodynamic instability because of cardiomyopathy and stress cardiomyopathy, and you've got a combination of pneumonia with failure, and you may want to put them on that. That is fine. That's absolutely okay to do. But you should be able to crystallize in your head ECMO to what. And if the answer is not clear, that's when I would say no for ECMO.
Okay, sir.
Shrikant, over to you.
Yeah, perfect. There's a good discussion on ECMO. I would like you to go back to from a invasive to more non-invasive thing. What do you think? What is the role of POCUS in the management of ARDS? Really, will it help? Will it not help? if at all it helps, how will it help? What are the different components of sonography or POCUS which you can use for the patients of ARDS in diagnosis, whether in management? Can you just either of you
Regarding,
can just
we can use POCUS in diagnosing whether it is a lung shredding is there or not, whether it is any.
no, that is okay. We talked about lung shred sign, which
Actually,
is a classical of
uh,
pneumonia. Now I'm talking about a full-blown ARDS, and how do
yes, sir.
you place the POCUS, which is a bedside, which is non-invasive?
We will see for
Uh,
lung aeration score, sir, ultrasound guided.
yeah, yeah,
Before proning and after proning, we will check, sir. Usually it
right.
has A, B1, B2, and C points, sir. Where will divide our lung to 30.
0 to 36 points.
Actually
Okay,
divided six zones in one lung and 6 zones in other lungs, sir. So that
okay,
we'll have 0 to 36 points, sir. We will
okay,
calculate these points before we will do a POCUS before proning the patient, sir, and we will
okay,
do a POCUS after proning the patient. And
right,
we will calculate these points, sir, and we
right,
will do a difference between before proning and after proning.
right.
But all this lung ultrasound aeration score, if it is more than 5, with the
Yeah,
posterior lobes consolidation which has been improved, then we will say it is a good prone responder, sir.
right.
If all the
So
PMO2s have been improved, but there is no improvement in the focus, then we will say that only perfusion part has been better
taken care.
than.
Then that X-ray
So
to
why? So this will be, this is an emerging concept which I'm sure
Yes, sir.
you are with Dr. Venkat, so he must have obviously told you about the emerging concept of phenotyping of ARDS.
Yes, sir.
That can be done with the help of POCUS, whether they are recruitables or they are non-recruitable lungs,
lung.
depending on the presence of B lines, whether they have reduced, and with the PEEP, so it becomes a recruitable.
Yes,
Okay, it
sir.
helps to individualize at the end of the day what you want to manage this patient. So at the end of the day, it will help you to individualize the patient, whether what you are supposed to do with the PEEP, whether how often the prone position or the prone intervention is required, and whether the recruitment, as Dr. Rahul correctly said, prone position is the itself is a recruitable maneuver.
Yes.
So it will obviously help you to guide the even the ventilator strategies, isn't it? So if you detect the over distension, like if you find that the A lines and the B lines
Sir.
have gone with high PEEP, you can have something like assessment on this kind of features, whether you identify the consolidation at the dependent areas, or you find more and more A lines and B lines disappearing on the anterior lung
Yes, sir.
with a high PEEP. So, you can monitor the response to the prone position with a dynamic real-time ultrasound at the bedside, which is not possible with the X-ray, or even you can't get this patient
Yes,
to the
sir.
CT scan. So, I think at this present point of time, we need to actually uh, put our head into how best we can use this non-invasive modalities as far as the diagnosis, the monitoring, and even the management. It's not only the lungs. You will obviously see the heart, you will see the IVC, you can have the lung water assessment depending on you already were having challenges to treat this patient in terms of anti-pro BNP, so you were on diuretics, and you can also monitor the disease progression. You can track the aeration loss, you can assess the response to therapy, and at the same time, importantly, you can also have some uh, pointers or insights towards management of complications in these patients, like sudden worsening of the PO2s, sudden hypoxia due to pneumothoraces, or VAP related consolidations if the patient is ventilated for a longer time, and of course right ventricular failure, which you actually mentioned in this patient, where they can have acute corpulmonal in ARDS. So I think POCUS will definitely aid in diagnosis and exclusion of cardiogenic pulmonary edemas in few situations. Like in your patient, I would probably have used POCUS more frequently to assess the therapy as well as to monitor the therapy, assess the recruitability. And you are quite fortunate enough to get away with this patient on day 4. I'm highly impressed by your result and patient getting extubated on day 4, because I'm really this thing, because if a pneumonia who comes to you after a couple of days in outside hospital, especially with underlying smoker, with such a dense pneumonia, the shadows getting away so fast in the matter of 4 days, uh, it's really creditable. So the outcome was pretty much very good, and there was a lot of learning points as we discussed. Yeah.
Oh, well said, Shrikant. Was this a pneumonia or was this all fluid? Did the
Well, I am
antibiotic work
forced.
or did the world's best antibiotic Lasix work?
I am forced to think that way.
Because another thing so I was actually going to ask that question in the beginning only, that was there any hemodynamic instability at all?
There was no
Did this patient
hemodynamics.
require any inotropes? Did this patient require any vasopressors?
He did
If you
not.
have a pneumococcus or streptococcus pneumoniae, see, simpler the organism, the more virulent and dangerous they are. So to have an ARDS of this type bilaterally and have a hemodynamically stable patient, you need to start thinking that was it the fluid which was causing more? See, nobody's challenging that there was no pneumonia. Okay, so there must be a streptococcus pneumonia.
Yes,
But a horrendous picture may be actually a
fluid.
combination of fluid and pneumonia.
Yes, sir.
Because if you sort of get away without a hemodynamic instability on day 4, day 5, you would start thinking that look, it does look highly unlikely that this patient may be having a severe dense pneumonia causing all of this.
Can you please go back to the CT picture? I mean, were there pleural effusions on the CT or on the POCUS anytime?
We
That would give us some guide about whether it was combination of fluid and, because here I could clearly see the air bronchograms, which are very nicely seen bilaterally, and plateau pressures and the dynamics can go or behave the same way in cardiogenic pulmonary edemas as well. So I, from whatever I can see, I cannot appreciate any fluid here, pleural effusions.
In POCUS also, we didn't appreciate any fluids, sir.
Okay, so that would have just, it's not that it can rule out, but it can just kind of associated finding uh, related to whether it was a combination of overlap of fluid overload along with this. And how was the sticky, you have said the bronchoscopy which was done. I think you have mentioned about the characteristics of the secretions as a thick mucoid secretions. Yeah. Okay. Yeah, whatever it is, I think it was a fantastic results. As far as if I'm a relative of the patient, I will be the most happy person getting away with such a pneumonia in 4 days. It's incredible job. Because these days I'm just sharing few couple of the pneumonias which we saw in the last couple of days, with a history of travel. You have taken that history, and so if they are traveling and if there's a traveler's pneumonia, they don't do that well. That is whatever the small experience I have, they will never do that well, especially with underlying smoking status. Number two, they will not get wind away so fast. And another thing is that I could see and we could grow aspergillus in couple of patients. So that was another thing which was quite unusual in absence of immune suppressed status. But there was clear molds which were shown to us by microbiologists. So that was something which I remember, that we had kind of a super infection with aspergillus, and it is not unknown that in few pneumonias you can get super infection along with bacterial pneumonias. That's it from my side.
There is one question in the chat box. The steroid in the patient with severe CAP, with a high anti-proBNP, whether it is justified or not. And they said that DEXA is preferred with as no extra fluid retention, 100% glucocorticoid effect, hydrocot, and maybe methylpred can cause more pulmonary edema. So, anybody, Dr. Vinay?
Yeah, I think one of the students have already answered in a much more comprehensive fashion, quoting the guidelines. Of course, we prefer DEXA. There is no doubt about it in the trial, and we don't recommend MPS whatsoever in any of the recent guidelines which I am aware of. So I think yes, we will definitely prefer DEXA.
So, I think, sir, there are no questions. So as this is a very fantastic discussion, 1 hour and 5 minutes, totally, absolutely. So we have discussed from like how Berlin definition now turned into global definition of ARDS in 2024. So we are discussed regarding our plateau pressure, driving pressure, and recruitment maneuver. As in 2017, their paper was there, recruitment maneuvers apart from improving oxygenation, it has no any mortality benefit. And proning itself is a best recruitment maneuver. So I think a recruitment maneuver is in doubtful now. I think nobody who's working in the ICU doing it at present recruitment maneuver. So, and paralysis as again up to 48 hours, there is good evidence of patient paralyzing. Beyond 48 hours, then again it is doubtful. Don't have a clear consensus on it. And as Sir Srikant sir had pointed out, POCUS might be more frequent. POCUS might be probably it will guide us how the recruitment or how the things are happening. Probably you do POCUS and you do prone, and you see how the aeration or how the recruitment is happening. That is how we can frequently track and how the things. And as is ECMO again, later the course of the disease, ECMO is again doubtful. We don't have much clear guidelines. As CT might be some way whether the reversibility component is there or there is a fibrotic component is developing. Probably there is no straightforward answer. And as such, ECMO is a bridge to either in this case recovery. But again, we have to think a lot of logistical issues as well as patient recovery issues. So may not be a probably as the day progresses, the ECMO choice may not be strong whole good as in early disease process. So, sir, anything from Sir Rahul, sir? Anything from Srikant sir to add?
No, I think yeah, you have covered everything what we discussed, and we probably have got some take-home messages as far as the exam is concerned, and I think you must have got some ideas as to what will be asked and how does the exam course goes. And I think it was a nicely presented case with your mentors, Dr. Venkat and Dr. Durgesh here.
Thank you, sir.
And my very good friend and a senior and my guide, Dr. Rahul. It has been a pleasure again to share the Zoom platform with you. So if I may
It's a
say so,
pleasure. Likewise.
Dr. Rahul was the one who taught me the central lines when we were postgraduate students at JJ Hospital. So it was nice to have those memories again through Dr. Venkat and Dr. Durgesh. So thank you very much.
Rahul sir.
No, look, I think you guys did a fantastic presentation, crisp. You had answers for all the questions, and I really appreciate the way you presented it as well. I believe that you have a very good teacher and a mentor in form of Dr. Venkat, Dr. Durgesh and his team. So continue doing that. Continue to learn. See, learn to be precise and crisp. Learn to justify your answers. Learn to say no for processes which may not be helpful. Okay. So that's where you need to be able to justify things. Just because a pulmonologist says हम बाल करेंगे बाल करने का जरूरत नहीं है. Just because somebody says हम CT करेंगे CT करने का भी जरूरत नहीं है. Lot of things you can actually get away by not by being more scientific. Let me put it this way: by not just documenting it, but being more scientific. That we actually need to do this.
Okay.
Fantastic, but thank you.
Thank you.
Excellent.
Thank
Sir,
you.
It was a pleasure for me as well.
this will do word
Venkat, your sound.
this will do world of good for both Vinay and I'm not able to hear.
Yes.
Now you are okay.
Now audible.
Okay, I'm just saying ki, both of your appreciations or comments will do world of good to both Dr. Vinay and Vaishnavi for their upcoming exams and the performance. Best wishes
you.
and thank you both of you. Wonderful
Thank you.
flow, and as usual, Rahul sir and Srikant sir for your valuable moderation and wise, crisp discussion. So thank you very much.
Thank
Thank
you.
you.
Thank you,
Bye-bye.
Venkat.
Thank
Thank
you.
you,
Bye.
Durgesh. Thank you.
Thank you, Rahul
Bye.
sir. Thank you.
All the best.
Thank you.
Thank you, sir.
Thank you.
Bye-bye.